Tired today, but there we go. Right, I just want to do a little straw poll, find out who everybody is. So hands up if you're a social care worker of some kind. Not a healthcare worker, you work in social care. Care? 3 people. Okay, hooray, finally got there. Hands up if you're a H-Danny person. Okay, then that little corner. Hands up if you're a dietitian. Speech therapist. Physio, OT, doctor, social worker, counsellor of some kind. What have I missed? Nurse. Oh, right. I'll get my coat. I think there was one I've missed. Hands up. Who's a nurse? A few nurses. Who else? What else have I missed then? Therapists. Generic therapist, like a psychotherapist. A holistic therapist. Okay, cool. Right, I just want to get the sense of the audience. I've got lots of questions here, some of which are going to go to Liz. There's a little pile here, Liz's questions. There it says, how many different drug trials are currently happening in HD? New developments in treatment. Is there a research site in Northern Ireland? Which innovations are you most excited about? There you go. So those are your, I'll just pass those on. Right, so we're going to teach you how to speak Birminghamese now. Can you understand what the second what the patient's saying? I'm all right, Bab? Basically means I'm fine. So this is sort of if you want to really distill it down to the essence of the Huntington's world, this is my clinic, which I've been doing for 35 years. You sit down with the patient and the husband or wife, who sort of sits next to me, slightly behind the patient, and the patient's next to you, and you say, okay, hi, how you doing? How are you feeling? And they say, I'm fine. And then the husband or wife starts crying or going, not fine, really not fine at all, but it's trying to do it in a way just behind them so the patient can't see it. Or maybe they just burst into tears or something. And then the patient looks round a little bit puzzled and like, what's going on there? I don't really understand. And then they might sort of depending on where they are in the illness, they might on one level go, okay, that's clearly a problem here. Maybe I'll just put my hand on their hand on the side of the chair a little bit, but I don't really quite understand what's going on. And then at that moment, usually the spouse starts crying even more, because not only is there a problem the person doesn't know about, that in the room there's also a problem the person doesn't really get what's happening in the moment either. So I think that's a sort of double whammy. We'll come back to that. And if you were to say what summarized the sort of what it's like to be a person with HD, I think that's probably summarized it more than any other thing that I know. That little conversation, which is probably about 60% of my clinic beginnings. How are you? Fine. Husband or wife starts crying quietly. They don't want to make too much of a noise, because if they see them crying, or the patient might then start, why are you getting crying? They might get angry about it as well. So that's another thing that comes with it. Okay, so what we're going to talk about? These things. Bit of biology, a little bit about the striatum, that's a bit of the brain that predominantly goes wrong in HD, what it does, and then talk about some of the main mental disorders that we see, or the main mental changes. And I guess the big one is depression and anxiety. Those are big ones. Suicide is also one that we need to think about. But then this group of conditions, which are almost always present in HD, that we rather clumsily call organic personality disorder. Sometimes it used to be called frontal lobe syndrome, but then it wasn't just the frontal lobes. So we don't really have a very good name for it. But it really encompasses these two things. Problem with executive function, which is sort of multitasking, higher level planning things, and then also problems with social cognition. That means understanding other people's states of mind and being able to read a room. Those two problems, I think pretty much everybody with HD will get it at some point in their life. The ones with the very small mutations don't always get it. But most people with HD get a bit of that at some point, and most of them quite a lot of it. Okay. Right, we're going to do a bit of biology, but not very much. The thing you need to know from here is really this. Oh, hang on. Let me get the little pointer thing. Little pointer thing. Laser pointer. Here we go. Here's the Huntington's gene. Liz is going to tell me how many bases are there on the Huntington's gene. How? Yeah. I mean, 10,000 maybe? So is that 7,000? Does it? Okay, this, well, it's something of that ballpark. And here's right at the very beginning of the gene, this little bit at the beginning of the gene, there's these little bases, CAG, and that little sequence gets really expanded, basically. So instead of having if you haven't got HD in this room, you probably have about 15 of those, 15 CAGs in a row. And if you have got HD, you may have 40 something. And that little change, each of those CAGs codes for a little bit of protein called glutamine. Well, it's a bit of amino acid called glutamine, and all those glutamines come on a big long chain, and that chain here's the protein itself, makes the protein fold in a bit of a funny way. And that's quite a subtle small change, and that causes the problem, basically. And the longer this expansion is here, then usually the more early and the more severely you get the illness. So that's the thing to remember. The big long number of CAG repeats, they cause the protein to fold in a funny way, and that makes it very slightly toxic. But the important thing to remember here is, Huntington's, you say, well, it normally starts in your 40s, that people would say that, wouldn't they? I suppose I would get you to look at it in a different way and say, this process here starts from conception. It's actually, and it might also be that slightly changed protein might be a slight advantage to a developing brain. Because proteins aren't either good or bad, they can have good and bad qualities for a human. So actually that expanded protein, slightly changed protein, might be advantageous if you're about 6. But the older you get, the more it turns into a disadvantage, and it gradually overwhelms the cell. So what I want you to remember is not an illness that suddenly switches on in somebody who's in their 40s. It's actually something that's ongoing throughout their life since conception. And the brain's amazingly good at sort of adapting, having workarounds. We don't use our brains that much, actually, in the big scheme of things, so we can get by without using it that much. And so all that stuff can be accumulating in the brain. You can be losing a lot of brain cells and still being sort of okay, really. So it's not like the illness suddenly starts when you're 40. That's only just when we can start to see it, which is a different thing. And that's relevant for thinking about early symptoms, and it's also got a lot of relevance in terms of treatment, because actually if we could treat this thing really, really early, even before we could actually see it, that might be a good plan, although it's fraught with difficulty. So that's just a little bit of biology, and just to show you, it's neurodegenerative. So the best way of thinking of neurodegeneration is what it says on the tin. It's a gradual process, it's pretty linear. So it's just every month and every year you lose its brain cells are performing less well, and some of them are dying. And so you get that in the clinical world. You get one symptom and that symptom stays, and then maybe another one come along, and then another one come along, and another one will come along. Some of those symptoms will get a little bit better, some of the behaviour ones get better, but the cognitive ones get inexorably worse, and more of them as we go along. So that's what neurodegeneration looks like. But we can also get what we call motor symptoms, which you may have seen if you're working with people with HD. I don't get too bogged down with those because they're not usually a big problem for most people, except for later on. And chorea comes from choreography, which is dancing. So it's sort of dancing. If chorea was a dance, what dance would it be? I don't know. Body popping. Marching. Mashing. Moshing. Yeah. Oh, like a mosh pit. Yeah. Oh, yeah. Maybe, yeah, I haven't heard that one before. Yeah, well, you can decide for yourselves. And then dystonia is more like a fixed or very slowly changing posture. This sort of thing is dystonia, where your limb, usually it's often a limb or a trunk, gets stuck in a position that might be slightly moving. Like that's a dystonic thing. Whereas chorea is more like a small flitting movement. And I guess the thing you might see in a patient in the early stages that looks pretty good, looks pretty fine, and they go for a little walk. And when they go for a little walk, you might just see a little bit of flicking of the fingers as they're walking. And they see, if you notice, you can notice this in your patients now. And then there'll be a little flicking of things when they're walking. And then when they turn around, they're adding in another task. So you might see a little bit of dystonia at that point. So they might turn around, and when they turn around, you might see their hand go like that in a sort of little bit of a posture. And then they go back to walking, and it goes a little bit of flicking, and then they stop, and then it stops. So that's a sort of something you might look out for in somebody who's quite early in the process. Obviously, we know children get this condition too, but it's relatively uncommon. And they usually get a much more, it looks a bit more like Parkinson's disease. They're quite stiff, they speak very quietly, and they can often get quite a lot of dystonia as well. Whereas the adults who get it tend to get a bit more fidgety, choreic stuff. And of course, if you follow up people long enough, they will develop global cognitive impairment in almost every case. There are some exceptions, like everything I tell you, there's an exception to, so I'm going to speak in generalities. Okay, quick look at the brain. We're not going to stay too long on brains, but I'm just going to make a couple of little points. This is an okay brain, dead obviously, otherwise we wouldn't have chopped it up. Here's a HD brain, also dead. I just want you to look at two things. This is what's called a coronal section. So imagine, I call it sliced bread section. So my head's a slice of bread. I've sliced it down here like, and you look at it from the front like that. So here's one side of the brain, here's the other side of the brain. Do people get that? So we're looking head, face on like that, about halfway down. And this bit of the brain here is called the striatum. That's the bit that the neurons get really damaged in HD. And we're going to talk about that in a minute. And where's the striatum in this HD brain? It's gone, hasn't it? It's just nowhere to be seen. I mean, this is somebody who probably had very, very, very severe HD by the time they died. But it's also, you can see it's not just the striatum, is it? All the rest of the brain is somewhat atrophied. That's important. It has some important consequences in terms of the recent press release about the Unicure treatment, which is given specifically into the striatum, which is the most damaged, but it's not the only damaged bit in the brain in HD. So that's a potential limitation, I guess. I just want to show you this. We're going to get off the biology soon onto the brain, the behaviourology. These are people who are basically well. This is an example of a brain of someone who's basically well in a study called Track HD, where they took patients who carried the gene. They were well, they've got families and jobs and just functioning nicely, and they followed them up every year, scanning them. And I want you to look at this bit of the brain, which is the same bit of the brain I was showing you before, the striatum. But this is the sagittal section, which means rather than chopping it off at the front, somebody's chopped it off like, and you're looking in at the side. You got that? So here's the nose down there, that's the back, that's the top. Are you all orientated there? Good. I just want you to look at this bit, that's the striatum. I'm going to follow it year on year. And remember, this person is well the whole way through. So that's baseline, year 1, year 2. Can you see what's happening to that bit of brain? Let's go back again. Baseline, year 1, year 2. You see it shrinking. Now, you or I, as long as we don't have a neurodegenerative disorder, that bit of our brain after the age of, most people I think are over 25 in this room, not everybody. After about the age of 25, then you're sort of losing about 0.2% of that every year. Just to sort of, so you can orientate yourself. So I'm 61 now, I'm one of the more senior members of this group. So yeah, 0.2%, that adds up over 40 years or so. But these guys are losing 2% of remaining volume year on year, which is a factor of 10 times more. even though at this stage, in this patient, he's still fine. He's still fine, but he's losing a lot of brain. So his brain is having to work very hard to play catch up. And for most people, this is fine, but it does have implications for people who have very highly cognitively demanding jobs. I don't know, like aircraft pilots or hospital pharmacists or something, somebody who really has, and if you want to work in Tesco's or do probably quite a load of jobs really, you'd be fine. But there are some jobs with very high cognitive load that actually you might struggle even though you're symptomatically well from every other point of view. And that's important because those people do really, really important jobs that you don't want to mess up on. So that's one of those little things that's haunted me at different times in my career. So I've put this here. Motor onset. People talk about, has it started yet? This is, I would say, that's a silly question because it starts with conception. So has it started yet doesn't mean anything biologically. It's really just whether somebody can observe something in your body, the way your body moves. But by the time a person can do that, you're quite a long way down the track. Somebody said diagnosing Huntington's using the observation of chorea is like diagnosing pregnancy when you can palpate your first fetal limb in the abdomen. It's true, but it's a bit late. Or diagnosing diabetes when you've had your first limb amputated. It's sort of true, but it's a bit late in pathological terms. So I've put motor disorder as an artifact. And if we had another 3 hours, I'd give you a lecture about why we've evolved to have that "it started now" vibe, which makes no biological sense at all, but it sort of made a sort of cultural sense and got stuck, even though things have moved on. So that's a whole nother lecture. I'm nearly done with biology now, last biology slide. I just want to show you this because it's really important. I was showing you that bit of brain called the striatum. Here is it in a little section, just all on its own. And I just want to show you, I was taught at medical school that the striatum did motor things, and that's moving and coordination of movement, and that was it. Turns out that's not the case at all. Really what the striatum does, it's like a grand central station with everything to do with movement and behaviour. So think about, why did we as humans evolve to move? And why did we move? Why do humans move? What was the evolutionary benefit of moving? Survive. How does moving help survival, Ulsha? Oh, you've hit the two answers. Get towards nice things that would help survival, get away from horrible things that would get in the way of survival. So of course, all your movement systems are inherently linked to those systems, which are, is it good, should I go towards it? Is it bad, should I get away from it? I mean, it's as simple as that really, because simple systems tend to work really well. So we get loads of environmental information that comes into the striatum to do with where our body is, what's happening in the environment, what's in the external environment, what's happening in the internal environment, like in your guts and things. How much of that is a threat or an opportunity? So you've got a sort of emotional test on that too. Loads of sensory data, loads of emotional data, and then how might we fix it by using our motor system, get away from it, get towards it. How do we plan that? What might we do if things don't go quite according to plan? So that's quite a load of functions, isn't it? So we're just taking it away from movement and towards survival and evolutionary biology. That's where all this stuff talks to each other. All those bits of information get integrated in the striatum. And here's a nice proof of that through a monkey striatum, which basically shows those bits of the brain intricately interwoven with one another in the striatum. So what I want you to do, if you want, where we're getting round now, finally, to behaviour, and that is, imagine if this bit of brain here started shrinking at 2 or 3% a year, year on year on year on year. Imagine the sort of problems you might have with living, generally, getting on with the normal things you do, finding it difficult to organise the way you move towards things and away from things, and get the things you need, recognising danger, all sorts of things. If that bit goes, that's a major problem. And so I would say that is one of the main causes of the characteristic behavioural symptoms in Huntington's disease. The other main cause that you mustn't ever forget, of course, is that people with Huntington's disease also have a psychology. So they have the same psychology as lots of other people. They have loss. They also have, more specific to them, they might also have grown up with a parent with Huntington's disease. And so they may have grown up in a chaotic environment themselves with some issues with attachment as well. So they might have attachment problems, they might have loss problems, which are all, I guess, better understood with a psychological paradigm. Plus, they've got this biology going on too. So that's a lot. No wonder we get behavioural difficulties. And it's common for people to have those difficulties from both ends, from the more biological element and the more psychological element. Okay, what sort of behaviour? We're on to the clinical bit now. We've done the sciencey bit, as they say, on the clinical bit. What sort of problems people have? I guess from a sort of research point of view, the problems usually fall into two groups. The first one we're going to talk about a lot is irritability, apathy, poor planning, perseveration. That's a really striatal issue, I think. And interestingly, those cluster of symptoms very much track with the disease. So the poorlier you get, the more of those symptoms you get. They're a nice little cluster, and that's been shown 4 or 5 different ways. So I think that's pretty nailed down. The next cluster we see is very much a depression, anxiety, suicidal ideation cluster, and that doesn't track well with the disease at all. That fluctuates a lot through the illness and seems to be much more environmentally dependent. So if you look at depression, anxiety and suicidal ideation, you'll see there are big peaks early doors round about the testing time. There are big peaks when people are thought first, when people say it started now, even though it started ages ago. And probably a bit less on the whole towards the end of the illness. And we could talk about why that might be. There is another group of patients with HD who get psychosis, and they're not very well studied because quite a lot of the time they're in psychiatric institutions, so the researchers don't really study them, like how common is it, what sort of psychosis is it. We know it definitely happens. And you probably know, if you know of family, you might know of families who would say, with HD, who say, my granny was in an institution with schizophrenia. Anyone seen that? Oh, Katie's seen it. It's not that uncommon, actually. And I guess when we look back at that now, if we could travel back 50 years and we could apply genetic testing to them, we'd probably find out they had HD, I would imagine. That is in itself another talk, which we're not going to get into. I'm going to mainly talk about those first two things, the irritability, apathy, poor planning, perseveration group, and then the depression, anxiety group, because those are the big ones. Those are the ones we see every day. Those are the ones that we can do some things about. So, right, okay. We're going to talk about depression in HD because it gets missed, over and underdiagnosed, and just think a little bit about what happens if we come to clinic and we say to the patient, how are you? They're going, fine. And the wife or the husband goes, he's terribly depressed, doctor. He's terribly depressed. We're just like, how do we go about finding out what's going on there? So I guess the first thing to say is people with HD can look quite depressed when they're not. So it's always good just to be aware of that, because sometimes there's problems with expressing facial emotion, so they can look a little bit blank face when they're speaking. And also they might not function at a very high level. So the wife would say, oh, he just sits on the sofa all day watching telly and doesn't do anything. He's terribly depressed, and he looks terribly depressed. And then you say to the patient, how are you? And they go, I'm fine. So that's a tricky one, isn't it? Anybody got any solutions to working out what's going on there? What do you think might be going on? Any clues? Has anybody seen that situation or heard of that situation? I'm looking at the H-Danny people. Seen that? Katie's nodding again. Thank you, Katie, for support.
And apathy, does that come
Yeah, a lot of that I think is apathy. And it's a really simple question to say, how are you? I would probably expand the how are you a bit further and say, tell me about something you enjoyed doing. Or, and I suppose when we talk, and we call that anhedonia, the ability to experience everyday pleasure. And anhedonia is a really good question. So when you say, was there anything you enjoyed, people tend to think, oh, well, that was that time I went to that massive theme park or Christmas or something. Don't get sidetracked on that stuff. It's like, well, I had a nice cup of tea this morning, or my husband bought me some toast in bed and it was lovely, and I had toast and jam and a cup of tea in bed and that was lovely. So it's a gentle, or somebody was saying something funny on the radio that made me laugh. Or I had one yesterday in clinic, which was a really nice one. She said, oh, I remember Mum did that silly thing yesterday and I laughed. And she was in the clinic recalling what the stupid thing her mum did the day before and laughing in the clinic. And there was the carer had said, I think she's a bit depressed. I'm like, that really does not sound like depression to me. If you can recall something that was pleasurable in the moment and you can still record it and feel pleasure about it 24 hours later, that's not anhedonia. So I'm like, okay, I haven't heard that one before. That's a good one to remember. And people do find pleasure in other people's misfortune, don't they? So I think a mum did something stupid. It's like, oh, that's very pleasurable to know about that. That's the human condition, I guess. There are some things that don't really work in HD. I'm going to give you some examples that we normally use for diagnosing depression. Weight loss is a classic. A person with HD can lose weight, doesn't mean they're depressed. In fact, it usually doesn't, but sometimes, Or they might have changes in appetite, they might not be able to concentrate on what you're saying, they might have reduced energy levels. All those things in the common or garden world might make you think of depression. In HD, they're pretty much useless. The only way that they might possibly be useful, I guess, is the situation where somebody's had a certain level of those symptoms and that they've deteriorated over a fairly short period of time, like a few weeks. Because what we know about Huntington's is that it goes down slowly. If anything goes slowly, quite quick over a few days and weeks, outside the normal trajectory that you expect, then in the back of your mind you're thinking, okay, depression maybe, anxiety maybe, something else, alcohol maybe, or another physical thing like an infection or something. Like I just had somebody in clinic 2 days ago, and the wife said, oh, this Huntington's is getting worse quite much quicker than I expected. He's much more irritable and more apathetic. I said, give me a time scale. She said, well, we were on holiday for a week, and he wasn't not too bad at all. And then the day we came back, he was pretty bad, and he's been bad for a fortnight ever since. So, and he can't really speak or say anything. So we're trying to work out what's happened there. Anybody got any bright ideas? He might be exhausted. I thought that maybe.
Missing the holiday.
He might be missing the holiday. Yeah, and he's just coming out with, it's manifesting itself as normal HD-ish sort of behaviours like irritability, a bit more perseveration. I wondered, and also a bit of imbalance. I wondered if he picked up something on the plane on the way home, like a virus or something. So we're not doing anything. We're going to wait and watch a bit longer, see how that plays out. So time course is really important. In fact, I've put that down there, haven't I? Time course outside of context of disease progression. I'm glad. So I'm ahead of myself in what I actually wrote down. I suppose something I'd warn you against doing is if a person with HD comes to you with depression, you sort of, there's a temptation to go, oh, I know, I'd be depressed if I was in your position, wouldn't I? And there's some truth in that, but it's not, I don't think it really captures what's happening for the vast majority of people, in the sense of, that I'd be like you, that if I was you argument. You say, well, I wasn't like that 6 months ago, and I was still me then. So why am I like that now when really none of the facts on the ground have changed? Something else feels like it's happened. So I just feel like sometimes with mood changes, you have got to normalise them because we all have mood changes. But I think you've got to just be a bit careful about, that seems like a pat excuse and a reason not to do anything sometimes. So I'd just guide you against that a little bit. So, why might people with Huntington's be vulnerable to depression? Well, we've already gone through a bunch of things, haven't we? But basically speaking, they're more likely to have unstable attachments. As children, they're more likely to have traumatic early life events. They're more likely to have loss events all the way through their adulthood. I'm going to say one: driving, partners, jobs. Then the other thing you've got to be really careful of if you're a doctor, but everybody should do this really, in the 2-week thing where the person who went on holiday was fine, I'm thinking I'm going to just check about medications here, because medications can really hit mood. So if somebody has a mood change like that over 2 weeks or so, the first thing I'm doing, I'm going to the drug chart. And I'm going, oh look, you just went to see the doctor and he put you on 50 milligrams of tetrabenazine 3 times a day for your almost non-existent career. And then you've been depressed since day 1 and can barely get off the sofa. Well, that's why you need to reach for the drug chart and go, oh, hang on a minute. Oh, there's a correlation between when that started and your mood taking a massive nosedive. Maybe it's the meds. So you've always got to look at that one too. Very important. So on top of all these big stresses that your system is facing, you also have, when you're under stress, we have these things called coping strategies, don't we? That sort of helps us to ward off depression. When we just use our brain to rationalize things and plan strategies and say, well, if I do this, I'll make sure I go swimming every day, and I'll go to the doctor, I'll make sure I haven't got hypothyroidism or something, or anemia, and I'll change this and I'll change that and I'll try this. And then that's a coping strategy, isn't it? Well, we know people with HD can't do that stuff very well unless they've got somebody else doing it for them. So they get more life events and they don't have that natural strategizing coping strategy thing. So I guess the miracle is, why don't they get way, way more depressed than they do? And I think there's probably a reason for that in the pathology as well. So if you read all that, you'd think 90% of people with HD should be depressed 90% of the time, and it's just not the case at all. In fact, it's surprising how cheerful most of them are most of the time. Relatives are a different matter, but for the patient, they're quite often. It's one of the things I like about the illness. The patient's usually quite cheery, to me anyway. I just want to mention a little bit about suicide. First thing is, it's okay to ask. That's first. Don't feel like if I ask them about suicide, that's going to make them kill themselves. There's no evidence for that. You can still ask. It's fine. And George Huntington wrote, it is the condition that most leads to suicide. And he's not wrong, actually. Suicide rates are quite high. So it's not a problem to ask about that. But the suicide usually comes in little clusters. Again, with the depression thing, it often comes around about genetic testing time, and then at the time of the very first obvious losses. So I'll give you an example of that. There was a guy who was struggling a bit at work. He came home from work one night in the car and it was dark, I think 6 o'clock in winter, and he had a bang in the car, a sort of minor to medium bang in the car that was his fault. He came home, he told his wife, I had a bang in the car, it's probably my fault, blah, blah, blah. Went to bed, got up in the middle of the night, jumped off the motorway bridge onto the M6 and killed himself. And that is not thankfully it doesn't happen that often, but that sort of story, that sort of first, it's relatively early on in the illness, first starting to experience a loss, but still having enough cognitive function to be able to predict future outcomes. And you can sort of see that story, can't you? You're struggling at work, you're coming home in the car, maybe you're thinking about work, you have a bang in the car, you think, oh bloody hell, this is what's coming, sort of thing. But they still have enough future planning to be able to predict that, and enough initiative, and the apathy hasn't taken over, so they're actually able to execute it. Probably a bad choice of words, but you know what I mean. Okay, so good news about depression in HD. Like depression in general, somebody said it's one of the most horrible illnesses that you can have, but the good side of depression is it has a natural history and it often resolves. And that's probably truer in HD than in garden variety depression, in that when we studied depression in HD, we found that the prevalence was a certain thing, but the thing that was different about it to garden variety depression was, on the whole, each episode didn't last as long. So that's also interesting. It might be more likely to resolve on its own, which is another thing. I mean, we look at the NICE guidelines for depression. I think these days they say first thing you do is nothing, wait and see. I'm looking at the other doctor in the room who might be able to. And that's for primary care, I think it says, mild to moderate depression. First thing you do is wait a month, see if it's. Say again? Or CBT. Wait a month, CBT. We could talk about CBT and depression HD. Gosh, yes. Another lecture. Then you go, are they on some medication that they don't need? Because quite often people treat chorea because it's there, not because it's problematic. And antichoreic drugs can lower mood. So it's just worth looking into that. And good thing, these treatments often work. Either they often work or the natural history is such that it often resolves anyway. A bit difficult to know. But most people I know who've had depressive episodes in HD come out the other side. It's not common to see chronic depression in HD, in my experience. So here's a bunch of things that work. Antidepressants do seem to work well. I mean, we haven't done a trial on it. That might be to come. I just want to talk a little bit about social interventions, and something that can be a precipitator for depression in HD is cognitive overload. There's too much going on, and to illustrate that, I'll give you a little vignette. See, I'm talking too much now. I was meant to be discussing, and here I'm talking. I had a man, he lived in the Black Country, which is just north of Birmingham, and he lives with his wife and his two daughters, his daughters are in their 20s, and they're all lovely. And they're probably quite involved. Anybody know anything about the Black Country in Birmingham? No, it's where the Industrial Revolution started. It's a very community place, and families are very tight with each other, and they talk about emotions a lot. And, you know, it's sort of like, quite, compared to Birmingham, it's very family emotion. And like Birmingham, you won't see families talking about emotions at all, really much. But in the Black Country, that's a part of their currency. They talk about emotions and families and how people are getting on. So he lived with his wife and his two daughters, and most of the time they were like, "Are you all right? How are you feeling in yourself?" And he was getting actually quite depressed and or irritable. And his treatment was to go and live in a flat down the road on his own. And it worked a treat. And it worked a treat for his wife and his two daughters as well, because they saw him for 20 minutes a day, regularly, same 20 minutes each day. They had a lovely time, and then they went away and he had peace and quiet, and the depression just lifted, because he was just overloaded with too much thinking that he was expected to do, and he couldn't do it. Other things can precipitate depression are your first dysphagia episode. So you don't find, you choke on a fish finger, and then your mood takes a massive nosedive. So managing those symptoms in a good way. And general support, I put that in there, but that's not just for the patient, that's also for the partner. So I'm going to just throw in another bombshell of things to think about in HD in the partner is what I would call ambiguous grief. And this comes up in lots of places. So and ambiguous grief can drive depression in the patient and the partner. So ambiguous grief means you're grieving for a person, but they haven't actually died yet. But the amount of times you would hear, "This is not the man I married, this is not the woman I married, it's a different person, it's like living with an alien," or something like that. But they haven't died. So it's like, I'm grieving, but they've not gone yet. So that's a real sort of stuck moment. And quite often, if the partner in that can sometimes engineer, subconsciously, I think, engineer conflict, because they're so mad about that situation. They're so cross about that, what's happened there, that they'll engineer a conflict. And sometimes helping people gently through ambiguous grief you can get to some lovely places after that. and I suppose that's what I would say I mostly do in clinic, is helping partners through ambiguous grief. Because when they can get over the other side and they stop being so damn angry about the situation, which they're perfectly entitled to be angry about, then they can get on with accepting whatever it is that they do have, and what, maybe thinking of some things that they had before and working in a different way. So that requires quite a lot of, I guess, support, counselling, specific types of therapy, maybe, like acceptance and commitment therapy, maybe might be a good one in this thing. I think ACT for carers is a good thing. I'm ACT for carers. That's my slogan. Okay, I'm going to probably take you through two more areas now. The next one is irritability. So people with HD get antsy, don't they, on the whole? They get irritable, they have little outbursts, they feel cross, and sometimes they've got every right to be cross because all sorts of crappy things happening to them, and sometimes their cross comes out of the blue, and we call this irritability, which I've defined, this is my definition, an excessively angry response to a minor stimulus. In other words, I don't know, the smallest thing happened and they just blew up like a bottle of pop. So I guess the thing to remember about this one is to say that don't just say, oh, people with Huntington's get irritable. To say, well, in this particular case, what might be driving this irritability? Because there's a big list of them. You have to go down the big list and say which of these things it is. Now, if you've got a patient that can tell you, that makes the list a lot shorter and a lot easier to deal with. If the patient can't speak or can't make themselves known to you, that means the job is a lot harder because you have to be a detective then. Yeah.
In your experience, do you see any difference in male response and female response? And what I mean is, in my job, I find, and this is going to be really sweeping statement, but I find males more irritable that I'm working with than females, and I'm completely happy to be correct.
I hadn't noticed.
Really? Okay.
You're making me think now. No, I think I would say they're pretty much evenly. I think men are capable of more violent external expressions of irritability, but I think the basic underlying irritability process, in my experience, is pretty much the same.
Does anybody else find that?
Yeah,
Yes, maybe you articulate it better, but it's not their ability, it's your
it's what they're capable of doing might be different. Yeah, I guess. So this is my little list that I go through of things that might lead a person to be irritable, and you can see there's a lot you can do about quite a lot of those things. I think I'm going to add ambiguous grief from the spouse as well, but I think that might come under cognitive overload. Must never forget, of course, especially in people who are further down the line, the very basic physical causes that can make you irritable, and constipation is a classic in that, or even a tooth infection, and sometimes if they've had a bang on the head, subdural hematomas. So you just got to have that slightly in the back of your mind, because sometimes people with HD, after a certain period of time, their brain's like a little walnut sort of rattling around in the head. So, quite a small bang could give you a subdural. So that nobody's ever really studied it, but they're they're not super common, but they're relatively common in HD, especially towards the later stages. They might just be an irritable, grumpy so-and-so forever. They might not have become irritable, they might have always been irritable, which is an issue, really. So all of those have different treatments, don't they? Now, if you've been through all of that, and I've probably missed a few, and you still want to do some treatments, there are treatments you can give purely that will basically make a person's fuse a bit longer. And I think particularly if it's caused by perseveration, in other words, getting really stuck on something, then probably SSRIs would probably be a good choice first off for that. But I've just put a few things up there of things that drugs you might use, but I'm not going to do a talk on drugs because we've got one doctor here, so it's not really like which drug would you use sort of a talk. But I said mainly treat underlying cause, manage relatives, carers. That's the big job. Okay, we're coming to the end now. We're just going to do a little bit about social cognition because I think that's something that's been really neglected and it's really important. So going back to the beginning of the talk, when I say, how are things going? Person with HD goes, I'm all right, Bab. And then the relative carer does this face palm. And that's what happens in clinic. Here's a little picture from Jean-Luc Picard from Star Trek, going, what's this? When words fail to describe the dismay, there is always face palm. So there you go. And then I did mention to you earlier what we call double face palm, because not only does the patient not understand that he's not fine, he doesn't understand his wife's reaction to that in the moment. So that's a double palm. When the fail is so strong, one face palm is not enough. So we're going to talk about executive function and social cognition. And I guess a good way of thinking about executive function is to think about driving a car. So who's a car driver? Hands up, car drivers. Who's driven a car today? Who's thought about the clutch today? Got an automatic. Who's thought about the foot brake today? A little bit, maybe. A teeny bit. Isn't the brain amazing that it can do that? It's like, so you don't have to worry about all that hands and foot stuff. You can spend the whole time thinking about what you're going to do when you get to the Silver Birch Hotel and who you're going to talk to and what's that person wearing and what's for tea and, oh, look, a squirrel, sort of stuff. That's all happening. Your hands and feet gradually do it, just doing everything. Isn't that bonkers? We just take that all for granted, don't we, every day? Our brain's going, hey, don't worry about that really complicated stuff. We've got that covered. We'll let you know if there's a problem. You can think about squirrels. Isn't that just mind-blowing, really, that the brain can do that? But imagine if it didn't work, how difficult it would be. And I was just talking to Glenda about the situation where somebody's got their supper, they've got a nice beef stew or something, and it's on their lap, on a chair, on a tray, in a bowl, and they've got, I don't know, 999 emergencies on the TV, and they're watching that, and you wonder why they would choke. Because there's so much, that requires a lot of, balancing the food, you're looking at the food, working, trying to, the subconscious clutch version of that is your brain is looking at that food and going, well, there's some chunks of beef there and some carrots that look quite well cooked, but how big would the amount look in my mouth before I could swallow it? How much do I need to chew that? So you already prepare, all that cognitive work is happening that you didn't even know it's happening. How hot is it? Is it going to burn me? How long would I need to keep it in my mouth before swallowing? But then if 999 emergencies on the TV, you're not really doing quite so much of that because you haven't got the capacity. So the next thing you know, you've tried to swallow a lump of gristle and you're having a little choking fit and your partner has to slap you on the back. But then take another situation, common situation, you're living with your partner and depending on how old you are, your mum and dad come round or your kids come round with the grandkids, or Auntie Barbara comes round or something, and everybody's having a bit, coming around for a cup of tea and a chat and maybe some tea. Now that for a lot of HT people can be a big challenge, a super big challenge, because think about this in your own life when that happens. That is not a simple procedure. You all know it, because you've all done it, haven't you? We've all done it zillions of times. It's quite a complex bit of social executive interaction, that having some people round for tea. Doesn't seem like it on the surface, but you go and think about it in your own lives. Most times that's quite complicated. Who gets to speak, when they get to speak, what they say, your shared history, the various unspoken things that we're not allowed to speak about in the family. I don't know, I could make a list of all the things. And so what happens is, Auntie Barbara comes round with the kids, and you're sitting around, they're like, oh, where's John with Huntington's disease? Oh, he's in his bedroom on his own. Oh, why has he been such a, what's the matter with him? So I think he just can't cope with all that stuff. It's hard enough for the rest of us, to be honest. He can't cope with it, so he's gone. So it's a really good example of how normal multitasking that we sort of take for granted, a person with HD just cannot do quite often, and then we'll go. So what's the solution to that? Is it to shame him to come back in the room? Or is it to talk to the whole family and say, actually, Uncle John, he's fine, he's quite happy, but he can only take this, because of his illness, he can only take this in small doses. So he's going to come, he's going to have 5 minutes, or maybe even he's going to be in his room, and you could go and see him one by one and have a little chat with him. And by the way, when you're talking to him, don't butt in before he's had a chance to answer. Ask him a question, wait a little bit, wait for him, because he might need 20 seconds before answering to a question. So you prep everybody for that. Go and see Uncle John. How are you, Uncle John? Nothing. Still, I'm fine. What are you doing? Nothing. He said, I've been watching the Villa on the telly. So, and then Uncle John gives you a big hug, and you give Uncle John a big hug, and you think, oh, Uncle John's all right. Whereas Uncle John, in the big moment with all these other people milling around, has not got a clue what to do. He's like, I'm out of here. I can't be dealing with this at all. So that's multitasking. And that also applies when you're saying, we were going to do thing 1, but actually at the last minute we're doing thing 2. Or it can verge into the sort of autism thing as well, where you're saying, supper's at 5:30, and they said, well, it's 5:31. You definitely said supper was 5:30, and it's not here. What's happening? And it's seemingly, and then you have that discussion between him and his wife's like, for God's sake, John, what's going on? It was 5:32 when you got your supper. And he said, but he always say, but you said 5:30. And so as the doctor, I'm like, well, you're technically right. It was 5:30, but that's not the point. And he said, well, what is the point? Either it comes at 5:30 or it doesn't. So that's that rigidity thing that you can get. Right. Good. So I guess one of the bits of advice about that is keep things simple. Try not to do more than one thing at once. So that means when you're having your supper, try and have it somewhere quiet without too much telly on in the kitchen. If you can get people, not everybody wants to do this, obviously. Keep it quiet, put some nice gentle music on. When you're going for a walk, don't do too much yattering. Don't be on your mobile phone, don't be eating an ice cream. Go for a walk, think about walking. Then when you want to chat, sit down, have a chat, then have an ice cream. So you're sort of chunking it down a little bit more. And it applies to driving too earlier on when people are still driving. When you're driving, don't have the radio on. Try and practice thinking about driving when you're driving. So, right, we are really nearly getting to the end now. So this is what happens when we overload that system. We get anxious, we get phobic. It's very, very common that people with HD don't like going into town anymore. I mean, it's almost all the time. There's people say, town is just too much. I mean, I'm like that too, but to be honest, it's just really complicated, isn't it? First of all, you haven't got to walk into anybody, which is hard enough. You've got to work out what you're doing, and there's hordes of people. Maybe it's, I don't know, maybe that's Birmingham city centre. It's a bit different to downtown Omagh, I guess. So when you overload the system, you get anxiety, arguments, depression, withdrawal, all those things can happen. So what do we do about it? We educate people to understand what it is, and we keep things simple and we wait. So anybody wants to know the chapter and verse on that, I've noticed there's loads of copies of the book Hurry Up and Wait in the foyer, which can be purchased. And I think that's, if you want to really read the real deal on that from somebody who really knows, read that book. I would recommend it to all the carers of patients that I have. And it's quite readable as well. And most of them will say, I really got a lot from that book. I'm not on commission. Final thing, right, social cognition. So social cognition is really interesting. Again, it's one of those types of thinking that we just take for granted, don't we, most of the time? To think about what another person's point of view might be, to imagine another scenario that's not the scenario that you're in, so put yourself in somebody else's shoes. So an interesting sidebar is that the bits of the brain that deal with point of view in terms of opinion are the same as the bits of the brain that deal with points of view according to social, like how are you feeling? The bits of brain that looks at that is also the same bit that looks at like, what do you think about something and what can you see? For instance, I'll give you an example. If I show you this and say, what can I see? What can I see? What? I can see thank you. So you just put yourself in my eyes, haven't you, to do that? You'd think that was a very easy thing to do. Was that easy to do? Took a bit of thinking. But actually that bit of the brain is the same bit when you're looking at me and thinking, I wonder what Hugh's thinking about, I wonder how he's feeling. It's the same part of the brain, which is sort of interesting. And that's a problem in HD. So they find it really difficult to imagine other people's emotions, but also difficult to imagine another viewpoint apart from their own in that moment in time. So imagining being someone else in another place at another time in the future is really hard to do. And we do that a lot of the time, especially imagining things that might happen in your future. So how much of the time today have you spent thinking about things that might happen in a bit? It could be in 5 minutes, could be in 10 minutes, could be in 10 years. I mean, a lot, really, most of us. More so when you're young, I think. It gets a bit less, I don't know, maybe. And people find that really hard to do that imagining the future. And that can be a blessing, can't it? I guess, because for a lot of these people, the future is quite problematic. So losing the ability to do that quite so strongly, I think, does have some blessing elements to it, if you like. Not so good for the partner, obviously. So I suppose this lack of theory of mind, you would say, is a bit like Asperger's syndrome, a bit like autistic spectrum disorder. And a lot of our patients, when you see their behaviours, you think, it looks a bit like ASD to me, that. And I suppose that's how I think of Huntington's. It's really a late onset Asperger's syndrome of middle age in most cases, where we got distracted by all the moving about. Because we saw the moving about, well, that's clearly weird. That's clearly what's the problem, we should treat that. But we know with, developmental disorders, that's difficult to see. You've got to ask some more questions and find out about it, so you might not even know. Okay, so that's a new way of perceiving it, late onset Asperger's syndrome. Right, I'm not going to go into those things. I'm just going to go to what happens if you can't do those things. Well, you can't negotiate with your partner about how you're going to share things out. It gets really hard to do that. And that's very frustrating. Back to ambiguous grief. It can make you apathetic because you can't imagine the things that you might do. And then it can make you all those other things that I just put up there. So what do? It's back to that educating families about the nature of Huntington's disease, working with spouses, learning how to manage interactions, learning how to communicate a little bit more literally and a bit more concretely, keeping routines, and supporting all the people who are caring for the person with HD to make those adaptations, because that does contribute to this idea that this isn't the person I married, and it isn't in most cases. It's not the same person. It's a different sort of person, but that's a big task, probably the biggest task. Right. I've finished now. I've probably over-talked. Thank you. I'm going to stop now.
So my name's Glenda King. I'm a NHS dietitian, so I work within an advanced practice role. I'm based in Musgraves. I'm not sure who's all familiar with that site, but there's a neurology unit there, so that's where I'm based. I've been neuro-based nearly my whole career, and the last 6 years specialising then in progressive conditions. So I see a range of conditions as well as people with Huntington's. I'm very lucky, work with a very close MDT and a very good relationship with that, and a very pro-nutrition team, so I'm incredibly lucky, and I certainly feel very privileged with my career so far. I really enjoy what I do, and I enjoy going to work every day, so I think that's an honour to have a career like that. I work an extended role with feeding tubes in my job, so I was going to touch on that today. If anybody's any questions, just give me a shout after. I'm happy to hang around for a while. Some of these slides I'll fly through because I've got a bit less time, so any questions, give me a wee shout after, and put your hand up in between and you can tell me what you think. So we'll talk a bit about the barriers within people with Huntington's, what poses challenges for eating and drinking, and the potential impact that has in their presentation. A bit about oral support, and briefly about enteral, and a little bit about advanced care planning. That's something within my role that we've worked very hard at the unit to try to do a lot better. So I think it's something that we all need to keep in mind as well. So Hugh touched on a lot of these. Actually, I'm not going to read through them. You can read through it as I talk, but there is many challenges for people with Huntington's to meet their nutritional hydration needs, but also those challenges for families supporting them. This is incredibly stressful at times with the nature of the symptoms and trying to get them to eat and drink. For me, I think a lot of people don't want to be in social situations for eating and drinking because of the way they can manage with eating and drinking. I think that's quite isolating, but sometimes bringing them to the dining room and encouraging that social interaction can actually help with eating and drinking. So I suppose it's about getting to know them, as always, getting to know where they feel most comfortable and seeing how we can support that. I think within the MDT, obviously, with adaptive equipment can be really helpful as well. So what can we put in place to actually support these barriers? And often, simple things as well, like bowels and dentition. We chatted at the table earlier about oral hygiene, for example, and the impact that can actually have on oral intake as well. Weight loss, Hugh, I know you had touched on this earlier as well. Why does it matter? So sometimes people think, well, why does my weight matter? Weight loss in itself is a predictor of muscle mass, predictor of fatigue, and predictor of obviously somebody not meeting their nutritional needs. So it's not just about the weight, it's about what's leading to that weight loss. And within Huntington's, the metabolic demand of the disease itself is incredibly metabolic. The demand in the body is very high. So you're eating and drinking less, and your body requires more than normal. So that deficit is what, of course, leads to weight loss and leads to other symptoms as well. And for me, quite often that weight loss, it's how that affects their mental health then, because that they see that as a predictor, they see that things are deteriorating. So if we can stop that and we can facilitate that weight gain or weight maintenance, then actually the positive impact that can have on how they feel about themselves and their mental health. So why does nutrition matter? You can see there that if nutrition is compromised, it has many effects in the body, and that's just a few examples. That list could be exhaustive. Nutrition is paramount. Nutrition is the fuel. Don't put fuel in your car, it doesn't go anywhere. If we don't nourish ourselves, all of us in this room, as well as people with Huntington's, the body will not function to its full capacity, and we won't maximise their potential and support the quality of life. And that's what we're trying to do. We're trying to enhance quality of life and manage symptoms as much as we can. And if you look at, we talked about wound healing earlier on our table as well, skin breaks, GP visits, acute hospital admissions, a lot of those can come back to poor nutrition or nutrition that hasn't been supported or hasn't been discussed. I think something that's not thought about enough is hydration. So what impact does dehydration have? We talked about irritability. If that person who's already presenting as irritable is then dehydrated, it's going to enhance that irritability. And that's something which can so easily be supported and be enhanced. And that's, for me, that's why hydration is not focused on enough. And you look at cognitive dysfunction as well and the impact that dehydration can have on cognition. It's something that we don't always consider, but that's one of the first questions when we're looking at a lot of these symptoms is, how are you drinking? How much are you drinking? And how can we get you to drink more? It's seldom that I see somebody and I go, you're doing great, just keep drinking what you're drinking. For all of us around this room as well, how much have we drank today? So again, it's not just people with Huntington's, but it's more challenging for them. So we must focus on this as well. People often ask me, how do I know if I'm drinking enough? So if you're drinking less than usual, if you're thirsty, if you're dry, cracked lips, if you're getting headaches, and looking at urine, it's really simple. Looking at catheter bags, looking at urine output, there's really easy ways of telling if somebody is dry. Now you can be clinically dry, but you can also just be dry and not taking enough. It doesn't always show in the bloods, but you can decide if somebody is drinking enough, and obviously the impact then on bowels as well. And again, if we're looking at quality of life and medication absorption, constipation and regular bowels are so important. So we must be asking these questions, or we should be asking these questions when we're talking to people, either in their own homes or in hospital. So I'll not focus on this, but I suppose the main thing, if you think about the variation in our diet to support bowels, to support skin, to support weight, we need to have a balanced diet, and we need to encourage the different food groups when we're talking with people, when we're looking at social skills, looking at kitchen skills, we're looking at meal preparation and meal support. We need to ensure that we're talking about all food groups, because all those groups have a different impact on our body. I'll probably skip over this too, but we can support somebody through artificial means, but we can also support people through adding extra calories to food. This sounds so simple, but it makes a massive difference. If you add milk powder to full cream milk, you can double the calories. That's really simple. That milk is then used in their tea and their cereal to make custard, to make puddings, and you can fortify somebody's diet with an extra 800-900 calories. So these really simple ideas can make a massive impact if somebody is struggling. You know, milk, cheese, sugar, honey, get it in there, get it into the foods, and we can fortify a diet and add to calories without looking at the artificial means. We're still giving them the foods they want to eat, they're still giving the foods they're enjoying to eat, but we can add extra calories in. I have some wee leaflets I can give out later on. So I didn't bring supplements today, maybe I should have, but I think the role of supplements sometimes is underplayed. Supplements can massively change somebody's nutritional intake. So it's just to say that you see them in people's homes or see them in people in hospital, or they mention supplementation. Some of these supplements can give an extra 800 calories. That massively can double somebody's intake. They're not the first line, but they can be really of benefit. There's lots of different kinds of supplements. There's lots of different flavours. There's lots of different textures. So if somebody's on thickened fluids, there's pre-made thickened supplements we can provide. So it's just to say that they have a really important role. If you're not sure why somebody's on them, or if they're not taking them, that should be reviewed and something else should be tried. So they really can make a massive difference to somebody's nutrition if we actually encourage these. So I guess that's kind of a few tips. I think regular meals is something that is often not discussed either. The importance of breakfast, lunch and dinner. Now for somebody with Huntington's, that might be breakfast at 12 o'clock, but that's okay. So regular eating, regular hydration is really, really important. If the appetite is poor, aiming for perhaps 6 snacks a day or 6 small meals as opposed to 3. So I'm not suggesting it has to be 3, but I'm suggesting regular eating and regular drinking is really, really important. The nourishing drinks and supplements, like I've talked about already. For some of my patients with Huntington's, there can be taste changes and differences in how they perceive textures. So it's important, again, to keep trying different foods, to keep trying new meals as well, because that might change. And do you know what? I say to my nursing staff, on a good day, get the meeting, get as much in as we can, because the next day might not be so good. Or a good time of the day, so perhaps the fatigue sets in the afternoon, so let's maximise the morning time, let's get as much in as we can. So getting to know their presentation and their pattern and their fatigue levels, and making sure we're maximising the time of the day when they're at their best and the most willing to eat and drink. And eat the rainbow. So just eat all different types of foods, include all food groups, thinking about fruit and veg from a vitamin mineral point of view, as well as a fibre point of view as well. Okay, so don't negate those kind of foods that we still need, and prevent other health disorders coming as well. For me, keeping a track of fluid is really important. So if at baseline they're dry, how much fluid are they taking now? And try to increase that, but you almost need to know what you're aiming for. So I think, nothing takes away from a hydration bottle that you can monitor how much you're drinking in that day and keep a track on it. We talked at our table about modified food and fluids. So if the swallow is becoming impaired, speech and language input, and then within dietetics, we can give you advice about what kinds of foods to prepare in the families, and making sure that we're giving safe food and fluids for their abilities. There's a lot of the pre-prepared meals that can be bought into people's homes, and they will do the modified texture now. So level 4, level 5 and level 6. So even if there is swallowing issues, there is meals that can be pre-bought for that actual texture as well. So for me, this should always be an MDT approach. I appreciate that I work in an MDT team. For those community workers, that's not always part of it. But I think to still use the resources that you have at your disposal, to contact colleagues, to contact other professions that can come in and support with this. Hugh talked about that quiet environment at times is best suited, adaptive equipment, small and often, definitely. With the supplement drinks, they don't have to be given as a drink. You can freeze them and get them as ice cream. You can make them into custards, you can make them into puddings, you can make them into Angel Delight. So don't just give something as it comes. You can get different recipe books to make that in a more interesting way. So before I move on to advanced care planning, anybody here in this room have their own advanced care plan? Nobody. Okay. So I have made one. So I made my advanced care plan because of the work that we have done in our unit. But I always think it's interesting as healthcare professionals, if we're not advanced care planning, how can we expect our families, our service users, our patients to advanced care plan? So has everybody heard of advanced care planning? So everybody knows what it is. So why isn't nobody doing it? Okay, so we all know the benefits of it, okay? And pardon? Okay, great, okay. So I think for me, I learned a lot by doing my own, by going through the process, going through those emotions. I learned a lot actually, so I'd encourage you all. It is for every person, 18 and over. It is not for those with neurological illnesses per se. It is not for end of life. It is for every adult. And Department of Health have really good resources online. So if you want any more information, there's brilliant resources online, and I know a lot of the organisations do it too. So it's just what's important to each person. There shouldn't be a standard way that we're advanced care planning. I think it's what is important to them, what do they want to articulate here and now when they are well and when they're able to, when they have cognitive capacity to, what do they want to get documented, what is important to them. It is, of course, a live document. It can be and should be changed. It can be and should be reviewed. And it is simply their thoughts and feelings. I think what I try to say is, at crisis point, that is not the time to make decisions. And quite often the person will not be able to make those decisions. So let's have these conversations early and let's support advanced care planning. We have, in our unit, developed some resources. Again, I'll not go into it in too much detail, but I'm happy to share those. We've done a lot of work. Despite being a regional neurological unit, we were not having those conversations on a day-to-day basis with our patients. We were not advocating for advanced care planning, and we were not confident as a team. So we've had to work very hard to get those resources in, to get our staff upskilled, and to actually support this better. And I think those 4 pillars are really important, because it's not just about clinical planning as healthcare teams. It is what's important to them personally, legal and financially. So I always think of the 4 pillars, not just perhaps what we think of. I think that Department of Health logo is actually really important, because for me it's my go-to when they're like, well, what financial planning, what legal planning? So I think keep that in your head. It does align with Department of Health, so it's lifted from there. I know that Huntington's, you guys have done some work within this. Your Life, Your Choices from Macmillan, a lot of it is based around that as well. And each healthcare trust has a record of my wishes, which maybe you're all familiar with. So for me, any documentation can be used. I've also helped people type them. It doesn't have to be a standard document. And sometimes the opportunity for advanced care planning discussions just kind of happen. Somebody might say to you, I feel like things are changing. That's your in. So you need just catch those moments and have those conversations when they naturally come up, and you will find it a more helpful conversation, I think. Yeah, let's not go in, but what I will say is the #1 game changer in the unit was my handmade badges. So we wear these, we have ACP champions, and we wear these, and people say to me, what is ACP? That's my in, okay? So I would highly encourage to go make some badges and wear them. We never got these professionally made yet, but this is what we use. So I think it's getting that opportunity to have the conversation. They might not want to talk about it, and that's okay, but our role is to open up the conversation and make them know that they can advance care plan if they want. I was going to a little bit about feeding tubes, but does anybody work with feeding tubes or have a knowledge of feeding tubes? Yeah. Would you like a bit of an overview quickly? Do I have time? Yeah. So there's lots of different types of feeding tubes, okay? Generally, they're going into the stomach and into the jejunum, okay? But they all look a little bit different and they're all managed differently. So the first one you'll see on the screen there is a PEG tube, which is this, okay? So percutaneous endoscopic gastrostomy. So it's placed endoscopically. Often it is the first tube that goes in, and that's obviously has to be assessed and the risks and benefits weighed up, okay? So the middle part there is what sits in the stomach. So the bumper is what keeps it in the stomach, okay, to keep it in. So the manufacturers would say it can be kept in for about 2 years. We do often leave those in for significantly longer, but there's a point where they have to be removed and replaced because the tube can actually break down. There is risks, of course, with any procedure, and they should be discussed first of all as well. The other type of feeding tube then would be a rig or gastrostomy. So the terms are used interchangeably, but they shouldn't be. So rig and gastrostomy are the same tube, but they're placed differently. So a rig tube is placed radiologically, a gastrostomy is placed at bedside, but the physical tube is the same. So this is a balloon, at the end of the tube you have a balloon filled with water. So quite often PEG is used for every tube. Only this tube is a PEG, okay? The other tube is a gastrostomy. They're cared for completely differently. This tube needs to be replaced every 3 months and is held in place by a balloon filled with water, and that water has to be changed every week. A PEG, like I said, stays in for 2 years or more and it's got no water in the balloon. So they're totally different. So when we're training people or we're working with these tubes, it's really important we know what we're working with, because how can you care or support a family with the tube if you don't know what type of tube it is? So it's just that recognition that there's lots of different types. So my role in the unit with advanced care planning is to raise awareness, but also to do advanced care planning about tube placement. So I try to talk to everybody about if it happened in the future where they would need a feeding tube, is that something they would want? And it's okay if they don't want that, that's totally fine. But my job is to give them the information, give them the risks and benefits, and talk to them a little bit about it. When you're thinking of feeding tubes, it doesn't have to be used to feed through. It can be used just for medications, it can be used just for fluids, and it can be used for all three. So the other thing to bear in mind is it's people's choice how that is used, and it should be an informed decision. So those conversations should be started early, before crisis point, so that they have the right information. Many times in my career, a feeding tube has been put in, and then they come in to me, and they haven't even been told that the family have to care for that tube at home. Quite often, care packages will not support the tube, and families haven't been told that they need to, that's part of the care needed home from families, and families have to be trained. So that piece of information is crucial, because I've had patients then going to nursing homes before because it can't be supported at home. That's too late when the tube's in. That needs to be discussed way, way before that point. And the point in a feeding tube is to enhance the quality of life. So that's a really important discussion if a patient wants to stay at home, is how can that be supported? What does that feeding regime look like? Would it be a bolus regime where you're syringing it in, or is it through a pump? So that should be a decision to support the quality of life. A couple other thoughts and then I'm done. So consideration for vitamin D supplementation. If you look at the Department of Health, we should be taking vitamin D supplementation this time of the year. We quite often do serum vitamin D levels in our unit, and 90% are coming back low. So it's just a consideration that to make sure that people are thinking about taking vitamin D supplementation. The other bit of work that I'm involved in the unit is a nice guidance on fragility risk, assessing fragility risk and assessing the need for DEXA scans. So something to consider depending on the risk factors of your patient, if that's something that we should be protecting against. And I think nothing takes away from face-to-face family meetings where you're sitting down with a family and you're discussing all of these things and answering questions. So I think just that communication is really important. And just like we're doing today, supporting each other to actually support people with Huntington's. So yeah, that was a quick run through, really quickly. Any questions?
I have a question. Sorry.
Sure.
Do you know the way you were saying there, this like informed choices and people have to make their own choices?
Yeah.
What if it gets to a stage where somebody's sort of choking badly, fluids and the blend of food and everything else, and they're saying they don't want that? Can that be forced on them?
So no, if that person has capacity, then that should be a feeding at risk.
If they haven't, you know what I mean?
Oh, they don't have?
If they made an advanced care plan, say, and they said they didn't want that?
So it'd have to be an advanced directive, so they'd have to write that in. It depends on the situation, but I think that's something that should be discussed, is the risks then of them. So if they understand the risks, but even if it's in their advanced care plan, at that moment, if it's felt that that is a high risk, I actually don't know where that would go. Because if at that moment, if they can't weigh up those risks and they're choosing to take that food or fluid, I'm not sure actually, but if it was in their advanced directive.
You were saying as well that has to be reviewed and updated and whatever as well. So
absolutely, yeah. It's not a one-off document, it's a live document. And obviously only comes into play when they no longer can make decisions for themselves. So whilst they can still make that decision, then...
It's just something like when Behaviour talking about that, that they made the choice and you can see it and wanting to swell the people change very quickly.
Absolutely, yeah.
And, that could be something, because there will be people on big feeding and, different feeding.
Yeah, and that's something with the feeding, an advanced care plan around enteral feeding is just the beginning. You then need to discuss at end of life and as things progress what they want done with that feed, because it's not just that you keep on going. So I think those discussions, those honest and open discussions about what this might look like and what the challenges might be with continuing with that feed, because like I said, the point is to support the quality of life, not to negatively enhance that. Anything else? I'm happy to chat after as well. But
did we ask a question for Glenda while she's there?
Yeah, maybe. I suppose, Glenda, if someone, say there's someone who doesn't really have any family or any support, if they haven't made an advanced care plan and they maybe go into nursing care, would, some type of support for them to be fitted, like a peg feed, ever be fitted? Can that decision be made for them by...
It can be made in their best interest. Yes, it can be. That's obviously a best interest decision and there's a process to be followed, but it can be made in their best interest, yeah. And that's why advanced care planning is so important, because if no wishes have been expressed, that best interest decision will be perhaps taken a little bit more quickly than if they have expressed their wishes and documented their wishes. The whole point is advanced care plans are uploaded onto Encompass, and that's a live document that everybody can see. I know within the unit we had some challenges in where to upload and where to write those notes, but within Encompass you can do an ICP note, so we do ICP notes and then upload the document through media. There's probably slight differences in how that's communicated, but yeah. All right, thank you.
Hi guys, I'm Liz. I'm a PhD student at UCL. I'm in Dr. Lauren Burns' lab, who also passes on her hellos. I think she knows quite a lot of people here, and she was sad not to be here today. And so we work in the lab on biomarkers in HD. Yeah, sure. I don't have slides because they're not ready yet. So I'm giving a talk tomorrow on clinical trial updates. So I just thought I'd give a sort of brief whistle-stop tour of the updates to you guys today. We work on biomarkers in the lab. Biomarkers are quantifiable indicators of either normal biological function or of disease pathology or of treatment response. And so specifically in the lab, we're looking at NFL, which is neurofilament-like protein. And so NFL is a really important structural protein in neurons. And we know that when neurons are damaged, NFL is released, although we're not quite sure the sort of exact mechanisms of it. But we can measure NFL in the blood and in the cerebral spinal fluid. And whilst NFL is a general marker of neuronal damage, so it's elevated across lots of different neurological conditions, and also if you have acute neuronal damage as well, for example, if you hit your head, NFL would be released. In HD, NFL we know correlates with disease stage and also with CAG repeat length, and also various different markers of disease severity. So it's got this potential in HD to be quite an important biomarker, both from a safety perspective in clinical trials, because it's a general marker of neuronal damage, and also as an indicator of HD disease progression. My whole project and a lot of Lauren's work is looking at really characterising NFL in HD. So moving on to the trial updates. So traditionally, the drugs and therapies for HD have been looking at symptomatic, helping symptoms basically, rather than being able to modify the disease. And it's only in the last several decades that we've really been able to explore disease-modifying therapies. So in 1993, when the HD gene was identified, which was a huge collaborative project involving 58 scientists and more than 12,000 HD families, we finally had a therapeutic target that we could potentially target to actually modulate the onset or speed of disease progression. So as Hugh mentioned before, the HG mutation is a trinucleotide repeat, so this repeat unit of CAG, and if you have 36 or more of these, then you will likely develop Huntington's disease within a lifespan, and if you have 40 or more, then you're basically guaranteed to develop Huntington's disease. And this mutant gene leads to a mutated messenger mRNA, which then ultimately leads to the toxic protein, which is thought to drive toxicity in the cells. So it's this kind of mutant Huntington protein that most of the current drugs within the therapeutic pipeline are targeting. And so at the moment we have candidates from preclinical right through to clinical trials, which target at kind of every stage of this protein production. So from DNA to the mRNA to the protein itself. So very topically, some candidate drug, which I'm sure people have heard of at the moment, is the AMT-130 from Unicure. So this is a gene therapy. So basically, it's a virus or a harmless virus which is injected into the brain, and it contains the blueprints for a cell to be able to generate a synthetic microRNA which binds to the messenger RNA, which is normally produced in the cell, and causes it to be degraded, and so ultimately leading to less of the protein production. And this isn't selective, so it's binding to normal Huntington messenger RNA and also to the mutant Huntington messenger RNA. So we've recently had the top-line results from the 30, I can't do the maths in my head, but the 3-year, 36-month trial update from the AMT-130 trial. And so they've reported that there's from 12 patients who had the high dose of this gene therapy, they've shown an average of a 75% reduction in the rate of progression of disease as measured by the composite unified Huntington's disease rating scale, which is basically like a composite score which includes functional, motor, and also cognitive measures of clinical severity. And so this 75% slowing kind of means that for a person who was progressing normally, it would be compared to 4 years of normal progression. Someone who had the treatment would only progress 1 year. And this was also accompanied by an 8% reduction in NFL levels. And so I said before, NFL is a marker of general neuronal damage. And we usually expect in people with Huntington's disease that it would go up by about 12% across each year. So this 8% lowering from the baseline levels at the beginning of the 3 years is kind of further supportive of the fact that this drug kind of is providing neuroprotective efficacy. And whilst this all sounds really exciting, it's very, very early on. So as I mentioned, this is a trial which only 12 people received the highest dose because it's a gene therapy. It's permanent. You can't sort of stop taking it. You receive the therapy, and that could be, it's sort of one and done. That's you. The trials for them are very kind of slow, and it's kind of one person taken at a time. So it's like a very small cohort, and it's also just in a very narrow group of people at the moment. So it is being expanded, but also it's also worth noting that these gene therapies as treatments are really expensive as well, and it's also difficult to upscale them. So whilst these are really promising results, it's really important to remember that it's early stages. But something that is really good about it is that it's a proof of concept for the fact that Huntington lowering can have an efficacious effect on sort of slowing down the disease. And so, as I mentioned before, the majority of the drugs at the moment which are in the therapeutic pipeline are Huntington lowering approaches. So this is really great for all of the other programs that are ongoing at the moment, because it's kind of supporting that this is like a good way to go about trying to modify the disease progression. So another kind of big-ish news at the moment, or recent news, is the PTC's 518 candidate, which is an oral pill which is taken daily, and this is like a non-selective splicing modulator. And so basically, this is like a small molecule that it modifies the way that mRNA is processed. So basically, when you go from DNA to the messenger RNA, when it's first kind of produced, the RNA, it needs to be processed and kind of cut up and like re-stuck together to be able to create the final messenger, which will go on to produce the protein. And the way that these small molecules work is they kind of interrupt that processing, and they lead to the like premature degradation of the messenger molecule, which basically leads to reduced amounts of the protein. So there was a candidate from PTC which has recently met its primary endpoints for its phase 2 trial, which was the Pivot HD study. And so it was shown that in CSF and blood, it could reduce the amounts of the Huntington protein. And it also really promisingly showed no spikes in neurofilament light, where previously we've seen reducing Huntington protein can lead to sort of spikes in NFL, which can be kind of indicative of maybe there's like neuronal damage going on. And on top of that, we've even seen that at 24 months, the NFL is below baseline, similar to in the AMT 130, which again is supportive of the fact that there could be a sort of clinically or biologically efficacious effect from this drug. But this is just, again, from an early phase trial, so it wasn't designed to look at efficacy on the like symptomatic front, but they have kind of, trials include additional, beyond just their primary endpoints, which kind of determine the success or failure of trials. They include secondary and exploratory endpoints so that we can kind of have a better idea of how to like design the next phase of the trials. And so they did look at the composite unified Huntington's disease rating scale, and they found that there was like promising trends in that at the 24-month like interim. So this is, as I say, it wasn't designed to be able to look at this, so this is something that will need to be looked at like further to see if that is something like clinically meaningful. And so something that is quite exciting about this is PTC is a relatively small company, and it's been Novartis, which is a much bigger company, have now collaborated with PTC to lead the phase 3 trial, which is planned to be taken or run on a much bigger population of people, and also within early HD people. So they'll be able to properly kind of assess whether the clinical benefit that we're potentially seeing here is meaningful or not. And one other just kind of exciting or interesting update as well in the field, another splicing modulator from Skyhawk Therapeutics, which is the Sky 0515. So they have an ongoing phase 1 trial, which they previously had shown data from people just in controls and showed that the splicing modulator lowered Huntington, which we expected, and that it was safe and well tolerated. And so now they've got an ongoing kind of part C of this phase 1 trial where they're looking at it in people with Huntington's disease. And they've found that the splicing modulator lowers the Huntington protein in blood by 62%, which is like better than any pill that we've seen so far. So that's really exciting because at the moment, up until this point, we had to rely on injections and infusions to be able to get such a high degree of lowering of Huntington, which is obviously much more invasive and much less pleasant way to get your treatment. So a daily pill is much more accessible. And something else that they've also reported is that the splicing modulator also lowers PMS1. So PMS1 is a protein which is involved in DNA repair. So about 10 years ago, genome-wide association studies were performed, and these are basically studies where they compared the DNA from loads and loads of different people with Huntington's and looked at how differences between people's DNA correlated with the age at which people developed symptoms in Huntington's. And so from this, they were trying to find genes that could influence the age of onset of Huntington's disease. And so they found that genes which were involved in DNA damage repair were really highly enriched amongst these genes which were found to affect the rate of Huntington's onset. And we now know that that's due to DNA damage repair genes being involved in somatic expansion. So this is basically, Huntington's disease is caused by the inheritance of this expanded CAG repeat tract in the Huntington gene, but we know that across people's lives, this expansion or this expanded unit of polyglutamine keeps expanding. And so in a tissue-dependent manner, so in the brain where the neurons are most vulnerable, it happens at the quickest rates, but basically the number of CAGs people have will increase and increase and increase. And the rate at which this increases is really linked to the onset and the severity of disease. And so we now think that this expansion is really heavily influenced by the DNA damage repair genes. And so people who have mutations in these genes will have either slower or faster rates of expansion. And so this molecule, the Sky 0515, because it not only lowers Huntington but also lowers PMS1, it's thought that it could have a 2-for-1 effect in that it not only reduces the amount of Huntington protein, which is the toxic driver of disease, but it could also reduce the rates of the expansion of the CAG, which is another driver of disease. And whilst this is sort of a really interesting, a potential 2-for-1 kind of outcome from this therapeutic, we don't actually know yet, because this is very early on, whether this has an effect on the somatic expansion rates. So PMS1 is lowered by 26% on average in this trial, but we have no information yet on expansion rates and stuff. So we're expecting the full phase 1 results in mid 2026. And they've also recently launched a phase 2/3 trial where they're looking at safety and lowering of these two molecules, but also looking at clinical scores and also brain structure. So that will be when we really know the efficacy of this drug, basically. And so just also kind of going on the somatic expansion route. So as I said, like till now, kind of all drugs in the pipeline have been mostly looking at targeting Huntington's disease and lowering Huntington's disease. But now, because we have this better understanding of somatic expansion, there's a lot more drugs which are coming into the pipeline which are targeting these DNA damage repair genes. So at the moment, they're all in the preclinical stages, but there is a Locus 23, I believe is the company, are looking to have a drug which targets MSH3, which is another one of these DNA damage repair proteins, within the next sort of year, are looking to have that in phase 1 clinical trials. So it's quite an exciting time for the expansion of the therapeutic landscape. And I think that was all that I had on my notes. But yeah, I wish that I had my slides to be able to show you the data. But yeah, it's an exciting time. Basically, a lot to report on.
Are there any other questions?
Yeah, my questions. Yeah, for sure. So one of them was, what new innovation are you most excited about in helping those with Huntington's disease? And something which, again, is like of sort of very early, in the early stages and kind of nowhere sort of close, I guess, to helping just yet, but something that could in the future be really, really exciting is CRISPR-based editing. So basically CRISPR is like a tool which is kind of like genetic scissors, and you can go in and you can edit DNA. And so in the majority of people with Huntington's disease, there is a, within the like CAG repeats, just before the final CAG, there's a CAA codon. And so this still codes for the glutamine, but it kind of interrupts the CAG codons. And for some people, they don't have this like interruption. And for those people, there's a really dramatic effect on the age of their onset. So they will develop the disease on average 12 years before people who have this CAA, before the final CAG. And so it's kind of not really well understood at all why this is, because it's still coding for glutamine. But there's been some recent work, which I think is quite exciting, in human cell models and also in mouse models, where they've used CRISPR, which is a tool where you can go in and sort of like snip out DNA and like insert new DNA. And they've gone in and tried to basically change CAG codons to CAA codons. And they've found that in human cell models, when they apply this technique, in 80% of the cells it works, and in those cells they see like a slowing and almost halting of the somatic expansion, so of the CAG like expansion in these cells. And obviously this is very far from the clinic, because it would need to be scaled up to a human brain, and also there's it would need to be improved for to remove like unintended effects where CAAs are just getting sort of inserted into the genome, and we'd also need to prove that it correlated with symptom improvement as a technique preclinically before it went anywhere near clinic. But I think it's an exciting kind of, could be a huge thing in the future. And I was also asked how many different drug trials are currently happening for Huntington's. So as I said, I think the vast majority that are currently in the clinic are HTT lowering, and the vast majority of those are targeting the HTT mRNA or messenger RNA. I'm not actually sure of the number, but I would imagine that there was somewhere around sort of 10 to 15 trials going on currently. And then a lot more sort of in the preclinical stages, which will be like coming up in the next few years. And then I was also asked for new developments in treatments, but I think that was sort of covered in what I spoke about. And then finally, whether there was a research site in Northern Ireland. And correct me if I'm wrong, Sorka, but I believe that Danny are working with Enroll and a doctor in Craigavon to set up a Enroll 2.0. Have I wildly mispronounced? How, go on.
Yeah, so we were
Craigavon.
yeah.
Craigavon.
We were actually at a very good stage of getting the first Enroll site going down, but then Enroll as a big global and things were changing their protocols, so we're sort of on I suppose you kind of like a waiting list to get set up. But as far as we understand, everything's good on this end of things. It's just waiting for them to proceed to the next step. So yeah, so hopefully in the next 12 months we'll have spots set up in Northern Ireland.
Yeah, that would be great. And then I was also, Lauren told me that potentially Niall Pender, who's a clinical psychologist, is expanding capacity in Dublin and expects that people from Northern Ireland will be able to.
Yeah, potentially as well. Can you
potentially.
About that, Patricia?
Well, Niall has moved from Beaumont, but he's in RCSI now, and he's still doing the Enroll.
Yeah.
And he said since the research news broke about 2 weeks ago, he said about 20 queries for Enroll. So I think they will be looking to try and they have started to try and increase the appointments that they offer. I think there's about 106 last time I asked people enrolled, but now I guess there's a move towards looking at people who are pre-manifest, so that's I suppose difficult for people who are eager, who have symptoms and are eager to join.
Yeah,
don't know how they're going to manage that. I think they were concerned about the emotional, I suppose, aspect of telling people that they're no longer suitable for Enroll. That can be, I'm sure,
changing the priority, I suppose, isn't it? It was the case that anybody who wanted to join Enroll could join, but the way they're changing the protocol, they're trying to put more of a focus on people who aren't showing many symptoms yet, so that they can really target treatments a little bit earlier and things like that. And the site in Galway, as it started in Rowan. There's a site in Galway, but it's a longer story.
There's not a site in Galway.
No. Okay, there's been some changes.
There is a lot of issues around EU data protection and Galway hospital data protection and all of that.
It's not that straightforward, I suppose, is the bottom line. But for us in Northern Ireland, one of the biggest challenges we had was finding a neurologist or somebody who's suitable to be a principal investigator on the site. And then we did find somebody that remarkably has somehow got capacity, even though neurologists in Northern Ireland are ridiculously overworked. And this guy is really interested and he's got experience in other clinical trials and different things like that. So we're just kind of holding on to that and trying to get the other ducks in a row. So yeah, I suppose when there's news with research, people are very keen to, how can I get this, where can I go? And I suppose I'm kind of not negative, I guess, but realistic in saying, this is great, but there's so much more to be done. It's not just like you can turn up the site and someone get access to these drugs. It's not that straightforward, but we're certainly doing everything we can to move things in that direction. Yeah. Any other questions on your to-do list?
No, I don't think so. Unless anyone has any questions. Yeah, for sure.
The way there's talk about the 75% reduction for the people who are on the higher dose. Is there a measurement for the people who weren't on higher dose, like what the percentage was?
Yeah, there will. I don't, off the top of my head, I don't know what it is, but it will be. I believe so. Yeah, I could also find out like in a second for you, but off the top of my head, I'm not sure. But yeah, I'll look in a second. Yeah.
why are they waiting to 18 to test? If it's from conception that they have the pathogen, why wait to 18?
Well, I guess you've got to think two things. First of all, what could you do about it? And the secondly is, do you have the capacity to make a decision about what your future would hold and what the consequences of testing are? I suppose, so I think 18 is not a bad line to draw. The only other place I would draw the line is where it matters is when you become sexually active or reproductively active in some way, because obviously there's so if you were 16 and you're at risk and you became pregnant, well then that's a big can of worms, isn't it? Right there. But I would say probably 18 is about right at the minute.
But that has the potential to change now that there is new research.
Yeah, there's an international protocol on genetic testing for Huntington's disease, and there's a working group working on that at the minute to see if they need to change how they. I'm not necessarily sure if they're looking at the age at looking at genetic testing, but certainly they're looking at how the process works and if it's still the best approach, because like what happens here in Northern Ireland, and it should be more or less the same in other parts of the world if they have the services there, but like. If somebody came to us now, we have a really good relationship with the genetics team in Belfast, and so we could get somebody seen usually within a few weeks, or at least to get scheduled for an appointment within a few weeks. And what would happen initially is they would go and they'd meet with a genetic counsellor and a genetics consultant usually, and they'd talk through the process of testing and kind of what would be involved. Now, the actual testing itself, it's simple in a sense, it's just a blood draw and that's sent away to a lab. But it's more the emotional impact and the practical impact of what happens if you find out you have Huntington's disease. What's going on in your life at the minute? Have you got a good support network? Are you embarking on any huge life changes? Some people are triggered to get tested because they're thinking of starting a family. Other people might be, thinking of a career choice, joining the army or something like that. That's, it's quite a physical thing, or major financial decisions like buying a house. So it depends kind of what's going on with them at the minute. So that kind of first appointment's really just talking through the process, and then they schedule another appointment, and it's either the second or the third appointment they would actually get the blood test taken. At any point people can withdraw, and sometimes people do, and they put appointments off for a while and just want to think through things and talk to their family or their partner or whatever. But if people wanted to go kind of straight through the process and there was no major issues, you're talking really about 4 months from the first appointment until they get their results. And Patricia's nodding her head because she's so sad now that we have such good services here.
Diabolical, and it goes through phases where it gets slightly better, but at the moment it's a year for your first appointment.
Yeah, to get the first appointment.
Yeah, to get the first appointment. And there has been a genetics and genomics strategy just introduced last year, so we're really hoping things might change, but at the moment it's not looking good. There's a severe shortage of genetic staff, and there's only one genetic centre that does testing in South for a population of 5.5
million people. No, I mean, as I said, it should be the same in other places, but it's really not.
It's the face palm thing.
Yeah, it is. This is a double face palm. Double face palm.
Well, I would say the AMT results and the publicity that's gone with them has caused an additional headache. It's my genetics friends saying we're inundated with people who want to
lots of people now want to get tested.
It's not a good reason to test tomorrow.
But in fairness, I mean, the genetics centre try their best, and they would, if somebody was making family planning decisions, try to get people seen earlier. Or in the case where a child gets diagnosed, an adult child is diagnosed before an older parent, that the older parent might want to know to tell the rest of which side of the family. So they do try and have exceptions, and also people can obviously go through the process and then hold off on getting the results. So there's people that have decided themselves, I'm going to do this now and wait 5 years before I get my results for whatever reason, because then I'll be 50 or then I'll be 40 or then I'll be 60. So people can do that. So I suppose it's not as daunting maybe to go through the process and then think, I don't need to know the answer yet. I can know it when I want to know.
Yeah, and that's it. Sometimes people decide, I don't actually, I'm not ready for it now. I'm not ready to find out. And they can withdraw or they can jump back in at any stage. The only thing that's not provided through the genetic counselling services is therapeutic counselling, which we now provide to some of you here involved in the counselling delivery. But that's a huge gap as well. The emotional support in terms of going through that process, getting your result, whether it's positive or negative, and how you kind of deal with that, how you deal with communicating that to other people in the family. particularly if parents maybe didn't want to get tested and didn't want to find out, and now you know. And if you know that you've got it, that means you know that your mother or father have it, even though they don't want to know. So huge communication issues, and lots for counsellors. Thankfully, I'm not a counsellor, so I don't have to deal with trying to navigate that world. But one of the questions here, which is interesting, is what would you tell someone who doesn't know much about Huntington's disease? What's the one thing, like, I mean, you have to keep it snappy now, it's like a headline. What's the one thing you'd want people to know about Huntington's disease?
I suppose, like, how variable it can be. So, like, everyone, or it's quite commonly known that it's sort of based off your CAG length, but within that, for any given CAG length, their onset can actually vary like massively. So I guess it's kind of like quite unpredictable.
Okay.
Yeah.
Okay, Glenda?
I think it's an advanced care plan early, so starting discussions about advanced care planning and expressing their wishes so that their wishes are known even when they can perhaps no longer express those.
Yeah. And for all of us now, this is going to be on our to-do list next week, because the shame of me having to say, no, we haven't done advanced care planning, it'll be on our work list next week. Hugh, what about you?
There's just loads of things you can do. That's what I would say to people. There's loads of things, loads of places during the process that interventions can help.
Yeah.
Of all kinds.
Yeah. So we don't have a cure yet, but there is definitely lots of help. Tricia, what's the one thing you want people to know?
Well, I'd say it's the generational aspect and the trauma through generations. And I think that goes back to Hugh's point about the family history, because if people aren't talking about it, that's when you get the misdiagnosis and the lack of diagnosis, and, you know, people going for years being symptomatic, and where there could be interventions and they're not getting those interventions because they're not engaging. I could go on and on and on.
Yeah. Hugh, just a quick question about medication. In your experience, are there any, like, say, top 3 best meds? Top 3. What's your favourite? What's the most effective? It's kind of looking at anxiety and psychiatric stuff.
I guess. Oh gosh, that's a really different question. I don't want to take to. I suppose SSRIs for irritability and anxiety. I would say so. You know, sertraline or something like that. Also, a good drug that might give you a bit of sleep, a bit of appetite stimulation, and promotion of weight gain, a bit of antichorea is olanzapine, but don't go too much too quickly. Olanzapine, that's that one. And I suppose the other one for sleep and anxiety, I suppose mirtazapine, sometimes at smaller doses. That's like 3 things. You've asked me for 3 things. It's like that's like 20 million hours of talking. But
oh no,
I don't know if that was my question, was it?
Yeah, probably.
Mine was more about agitation and aggression. I'm a consultant psychiatrist in Bloomfield Hospital in Dublin, and so we deal with the advanced stages of Huntington's, and oftentimes a lot of the residents or the patients that are admitted come in with acute agitation and aggression. Sometimes bloods are normal, and I know there's triggering factors like hunger, pain, etc. But in terms of medication management, that's where there's a huge challenge. So olanzapine, a lot of the time, is not effective and sometimes can exacerbate hunger and weight gain. So far, I've only started since June. I'm a brand new consultant to the team. Clopixol has been quite effective, but I was just wondering from your perspective if you've had experience with that or...
Only a little bit, so I don't know. And I suppose I would always say, in those situations, always go back to your ABC charts and your behavioural analysis, because it's very common that staff will say, oh, it's completely random, there's no triggering factors. And he said, go back and have a proper look. You might find that there are actually some things that you have to look through your Huntington's lens. You might see some things that you have. Not always, I know.
Okay. This is more relationship issues, I suppose. How do you think you could best support the family members? I suppose in one instance we're talking here about the children who's got a parent with Huntington's disease. Anything in particular? I mentioned anger around their parents having the fact that I suppose it's going to be passed on, that the parent's sick. Is there anything you can think of in that regard?
I think that for children, they just need information, don't they? And they need a safe space and information. And that's what they need. Whether they can get it or not is another matter. And I guess that's why some associations have got some youth workers. They can do that a bit. Mm-hmm. Or sometimes it's a really good family member, an auntie or someone like that, who can take that position. But they need information and they need space, don't they? Yeah. But it's how to get that, that's the problem.
But actually talking about it is very important.
For sure, because they quite often want to, and that online support of that nature can work quite well for teenagers, because they can talk to someone on a screen in their bedroom and it feels quite safe for them, and that's worked quite well in some places.
Okay.
Can I ask another question? Sorry. So I suppose down south again, probably because there isn't a lot of specialist services, a lot of parents decide, oh, we're not going to tell the children until we're 18. How would you feel about that?
18?
Yeah.
I mean, it's difficult because families are all different, aren't they? Around our patch, then families are normally telling kids usually a bit earlier than that, particularly because kids ask questions early, and that why is dad being a bit weird, sort of thing. And also, kids are sexually active before they're 18 in the majority of cases, and so somebody at some point needs to sit down with them and say, there's some extra responsibilities here that you've got to have a little bit of a think about. And I guess personally, I would probably, if I had a child that was at risk, I'd probably be trying to tell them probably early teens when they can start to understand, depending on the kid, really.
Yeah, I mean, obviously some people do tell earlier, but I think it's a fear around, especially if the other parent has more psychiatric problems.
Yeah. They think, am I going to be like mum or dad or something? They would worry about that. Yeah, I suppose it's been okay doing it. There hasn't, because we do it quite a bit, and it's not really caused a big deal of problems.
And I think HDO do a good job on
they really do
creating awareness around the need for good conversations and as early as possible and all that.
Yeah, absolutely. So it does seem to be the general kind of consensus is drip feeding information that's age appropriate, that's not overwhelming, but that you're opening the space to have those conversations so that kids aren't afraid to broach the subject or to ask questions, that they feel that they can talk about it. Because in families, like we just hear it all the time, in families where there's no conversation, I mean, it's just the trauma, all the issues that they feel like.
Is HD on any equivalent of GCSE syllabus?
No.
Because it was on the UK GCSE biology syllabus.
Was it really?
As an example of a dominant condition.
Yeah, my niece said it came up in a class discussion, but it turned out that her teacher knew somebody with Huntington's, and during genetics they talked about that, and she was the only one in the class who knew what Huntington's was.
Because of its genetic nature, it's a real classical thing to teach you about autosomal dominant conditions. Yeah. And it was on the UK curriculum.
This is a very tricky question now. It's how you manage the relationships between people who are diagnosed and undiagnosed, or people who've been tested or don't want to be tested. I mean, it's not a straightforward question, I suppose, but we've all seen those families where there's major dynamic issues within the families. Some people don't want to talk about it at all or acknowledge it, or they'll be really helpful and really supportive to a family member who's symptomatic but don't want to acknowledge their own risk or don't want to think about their own situation. So any top tips there? What's your top 3 tips there?
That's about 100 different situations.
Yeah, it's a lot, like it is. Yeah.
Gosh, what was the first one you said?
How do you manage the relationships between tested and untested, or diagnosed and undiagnosed members of the family?
I mean, it's not. I guess the thing is, you might not be speaking to the undiagnosed, untested people at all, so you might not even know who they are. You might know about them, but you won't have any contact with them, and then probably won't have contact with services.
Yeah.
So all you can do is talk to the people you can talk to if you were there in the clinic. I mean, they've got there's an uncle out there somewhere who's affected, is not going anywhere near a service.
Yeah, and you get, I suppose, in some families as well, we've got a lot of dysfunction where siblings don't speak to each other, and there's all kinds of.
There was a really good session at one of the European conferences. I don't know if it was the last one in Strasbourg or the one before that, around 2 siblings talking, and I think they were from the UK, and they were talking about how they had each misunderstood each other so much that the person who didn't have the gene, the person with the gene almost felt not sorry for them, but sympathetic that they had to do a lot and whatever, and they didn't realise that the person with the gene felt like that about them until they started having this. It was somebody that did a project on it. It was really, really interesting actually, and just shows the need for good communication.
Well, that's it. It does seem to, with all of these situations, good open communication and having the proper resources and having the support there is what it comes down to.
The resources, somebody to enable the conversation really.
What about somebody who has no capacity to consent to treatment or doesn't want to engage with services? Maybe Glenda, you could come in on that. Sorry, put you on the spot. But you would have come across a wee bit of this, like where there's people don't really want support.
Yeah, no, completely. I think we all and with our the families that come through our unit on a repeat basis for respite, and patients that don't want support in families, I think it's everybody's right to make what we feel is a bad decision, but that's their right. So I know within my own clinical practice, I try to remember that it's their decision. All we can do is give them the information, support, and space to make that informed decision. But it's not our job to say that's right or wrong. For me, it's our job to inform and support and not judge. And I think as long as we've done that, then it's their decision to make.
And sometimes I suppose it's more about supporting the family than the person themselves, because maybe they're feeling the burden of the decision making that the person is making.
And there's always those interrelationships with families that we all have to work around, but I suppose who's best to deliver that information, who's best to support, and who's in the room. I mean, as she said, we don't have access always to multiple family members. So who's present? And I think the people that are present are who we also support and guide, for them to support and guide, I think.
The only bit I'd add to that is, well, in the north of Ireland, we have a Mental Capacity Act too, where we're allowed to make best interest decisions for people in, more extreme circumstances. I guess the only thing I'd say about best interest decisions, this applies to PEGs as well, when you're making a best interest decision, you've got to take into account the practical consequences of that decision. So it's all right to say it's in somebody's best interest to have a PEG, for instance, but if they don't want a PEG, then you've got to consider the practicalities of giving someone a PEG who doesn't want a PEG and what that means in real life terms, and weigh that into the best interests. Like, they're going to fight you all the way to the table. They're going to fight you afterwards every time you come near them with food. They're going to try and hit you in the face. That sort of thing. So that has, the practical consequences of your best interest decision, what that means on the ground, has to be taken into account in the decision itself, rather than some sort of abstract decision. And that's hard.
Yeah, I suppose, again, horror story from down south. We were trying to advocate for somebody to get services for about 5 years, disability services, mental health, safeguarding. Any service said that they couldn't help the person because they didn't have their consent. So the person's husband as well was trying to get support, looked to the Child and Family Agency, TUSLA, down south for social work and whatever. They advised him to take a protection order because the children were at risk because of the mom's symptoms. And in the end, he was forced to do that because there was no other alternatives or no support around it. 5 years later, she ends up going to prison because she couldn't comply with the court order. And that is the first time that she gets some services, only because we have one AMP nurse in Ireland that was able to go down and help her.
Mental Capacity Act equivalent to the South, because it's a European law.
Yeah, but the trouble is, I suppose, it goes back to how the person is judged to have capacity. Like, they don't look at functional capacity. It's a very simple capacity. And sorry, Sasha, I'm talking here about mental health. Sorry.
I mean, not all of the services are that bad. I think, we try our best. We're very limited in terms of what we can do.
Absolutely, but you are coming from a good service, and Beaumont as well is a good service. Yeah, but that's it.
The Capacity Act, these are things I have to do on a regular basis in the unit that I work in. And it is a little bit complex. There's been a change in the Capacity Act in the Southern Republic. So it used to be a ward of court, but now, to be honest, it's very new and it's hard to understand. I don't know what the question was.
Oh, absolutely, it's really hard to understand.
Yeah, so I guess the overall rule is that we have to assume a person has capacity unless there's clear evidence that there's not. So even if they don't have capacity, we have to respect their will and preference. overall. So we always ask what is their preference, and then if they don't have capacity, then we go with the decision-making representative route.
There's some nice stuff about what people have been calling 360 capacity assessment, 360 degree capacity assessment, which basically means if somebody tells you about something, you don't necessarily have to take their word that it's true. In other words, you're allowed to take evidence from all sorts of other places. And people say, oh, I'm fine, thank you, I don't do anything dangerous. And it turns out that they really do loads of dangerous things.
And I think that's the problem. There's less abilities or less feeling confident to talk to family members because of the decision support service. That there's more of a reluctance, I suppose, for health professionals to hear from.
And I would say, you sort of got my eye on my high horse now. I would say that these are often complicated, quite risky people, and sometimes a lot of services will say the person has capacity as a cop-out for getting involved. Absolutely. And I'm really... I went to see the patient, they said, I'm fine, I don't need anything, so I left, and they've got capacity. And you say, can I see your homework, please? Yeah. And it's like, well, what actually did they say? Did you put some risks in front of them? And ask them what they would do in that situation. Did you check that's actually what's actually happening? And did you document that? And you'll probably find 90% of the time it didn't happen.
Yeah. Okay, this segues nicely into what we do at HDANI, or mostly what the girls over at the table do. So we have Katie and Lynn and Rita and Clara and Maria, who's off on sick leave at the minute. So we have 5 family support workers at the minute. Look at Patricia. And in essence, I suppose these girls do a bit of everything because they're there to support the entire family. And I suppose I was over at the European Huntington's Association conference in Bucharest there a couple of weeks ago, and I was delighted actually for the first time in a long time to say, like, what we're doing is actually we have a really good service at the minute in Northern Ireland. Not, I have to say, thanks to any huge government interventions, but just persistence and lobbying and trying our best to do what we can with the money we've got. But we've got a really good service at the minute in the north, and I'm incredibly proud of the work that we've managed to do. And as I said, we're really looking at the entire family, so not just the person with Huntington's disease. And sometimes we don't really even see the person with Huntington's disease, to be honest. It's the other family members, the carers, it's people working in nursing homes or in care homes, and we're in supporting them in some capacity to ensure that they're well equipped to do their job. But we can provide support to every member of the family, from the youngest to the oldest. We have counselling available, we have therapies available. So we will help with everything from housing and transport and employment and education to benefits. And I suppose a big part of the job is trying to take, I suppose I call it, the mental load off the family members. We want to encourage and support independence and competence and capability as much as possible, but sometimes even just getting an appointment with a GP or, finding a social worker and things like that, it's just a huge burden on people, and it's a huge amount of just mental load. So to have somebody in your corner who can say, look at, well, who have you got on your team at the minute? Okay, well, these are the gaps, this is what we need, and let me do some of that, pulling things together for you. So from the point of whether it's genetic testing or, trying to get a review appointment with neurology or seeing a HD nurse, and thankfully you have 2 HD nurses covering Northern Ireland now, which is amazing too. And we work really closely with all of those people. So it's a kind of like a coordinator of health and social care and general listening ear and everything that we can possibly do to help. So yeah, I guess one of the biggest challenges we face is the reason you're in the room today, which is trying to educate health and social care professionals to know a bit more about Huntington's disease, but to know that we're here as well to help you guys. But also you'll find family members that we don't have a connection with, and I think roughly we have a connection with about 75% of the Huntington's disease community in Northern Ireland, based on all kinds of jiggery-pokery numbers. But we work with about 200 odd families at the minute, over 1,000 individuals on our database, and they all receive various levels of care. So some of them could just want to, come to the conference we've got tomorrow. Some people want to dip in and out of support groups. Other people will require regular check-ins, and we'd have like a traffic light type system where people will be kept There could be some people who maybe have a wee check-in every week to see how they're getting on. Other people, we have a kind of, you call us, you call us, we'll not call you kind of approach. But everybody is receiving some level of service, and on top of that then we have about 4,500 health and social care professionals like yourselves on our database, and they would receive invites to training, information, newsletters, things like that. So we're constantly just trying to expand our network and reach within the community and make sure that anybody who wants a service can get it, whatever that service looks like. At the minute, as I said, it is great, I have to say, brilliant, because the cohesion that we have between ourselves and the charity and the health and social care professionals who are working in the front line, like the HD nurses or the genetic counselling services or neurology, is great. So if we come across a family, they've never seen a HD nurse or they haven't had a neurology appointment, we can make that happen fairly quickly, just because we've built up those relationships and those systems are in place that we can kind of jump over. I'm not looking at Patricia.
No, we have one HD advanced practitioner at the moment, and somebody else has imposed it.
Yeah, so it does take. I mean, it takes a lot. Yeah, it does. It does take a lot. Like we had nothing for a long time, so it's great. So if you ever come across somebody with Huntington's disease, basically, it isn't all hopeless. There is lots of interventions that can make life a bit easier for them along the way, and there's lots of support there for their families. And that's the message I suppose I want you to take away today. So thank you so much for your time. On a practical note, you're going to get an email from amazing Rachel, who's out there keeping everything together next week, and you'll get some slides and PowerPoints and some various bits of information and resources. But I want you to know that the door is always open. If you ever come across somebody, just pick up the phone or give us a shout, and we can come out and work with your teams, or we can build on what we've learned today as well. Okay, so thanks so much for your time.
Thank you.